I think that this talk comes quite appropriately after these nice two talks by Dr. Pelosi and Constantin, because I think we show in a real life, I would say, uncontrolled setting, that what you have heard from these nice physiological studies is indeed happening, or at least there is evidence that this is happening. My conflicts of interest are not really relevant for this talk. I have to say that, however, I have a personal conflict of interest. I am very indebted to the people who worked with me in this study, to the society who made this possible, and to all the lung-safe investigators, and I hope some of them are in the room now. So the history of non-invasive ventilation in ARDS is a relatively recent one. For example, this is I would say, simple but very important study by Alexandre Demoule that has shown the evolution on the use of non-invasive ventilation over the years. So they sampled the 3 time points, 1997, 2002, 2010. And if you look at here on the right-hand side, these are the indications for the patients receiving NIV. So as you see, acute so let's say COPD exacerbation, to make a long story short, already in these patients NIV was used with a high frequency, but still it increased over the years, and also the rate of use of this equipment almost doubled for cardiogenic pulmonary edema. And this was due for sure to literature data showing the efficacy of non-invasive ventilation in these diseases, but I guess it was also due to the fact that in daily clinical practice, clinicians have noticed that indeed for these patients, NIV is very, very effective. And however, in what they called de novo acute respiratory failure, which I think included many ARDS patients, the clinicians seem to be, and the literature too, less convinced that this treatment could in fact be used with good results. So there is also another, maybe this is a little bit more semantic, there is also another issue with NIV and ARDS, which is the fact that the Berlin definition in regard to NIV is not very clear, because it says that PEEP or CPAP can be delivered non-invasively in the mild acute respiratory distress syndrome group. This is not a recommendation, it's a definition. So it's not very clear if you are on CPAP, but a PF lower than 100, in which category you should fall into. Some investigators consider that all patients under non-invasive ventilation should be in this category. Some others just classified them as if they were on invasive ventilation. Some said those patients cannot be classified. And again, this is maybe a bit technical, a bit semantic, but when it comes to enrolling patients in clinical trials, this starts to be, I would say, a more relevant question. So we thought when designing the LungSafe study that there were a bunch of questions that we could have answered to with our data in regard to non-invasive ventilation in ARDS. So we wanted to understand what is our current clinical practice, how often we use it, to evaluate whether the classification in mild, moderate, severe proposed by ARDS, by the Berlin definition, applies during NIV, to establish which risk factors are associated with NIV failure and death, and perhaps to see what are the implications regarding the use of NIV in terms of patients' management and outcome. Clearly, we have just observational data, so we hope that this can be used in the future to perhaps generate hypotheses and new RCTs. This is the main LungSafe study you are probably aware of, and in this study, in the main study, we did not include these almost more than 400 ARDS patients treated by NIV, and this study these patients were the cohort of which was the object of the secondary analysis of the LungSafe study, which we published later on. I would like to make a clear point, which is here for non-invasive, we define patients in non-invasive ventilation and as those patients who were undergoing NIV both on day 1 and day 2. So if a patient was shifted to NIV between day 1 and day 2, we did not consider this as a NIV failure. We've tried to be conservative. These patients were classified as invasive mechanical ventilation because we reasoned perhaps these are just patients who came to the ICU from the floor, from the emergency department, and at the first time point they had non-invasive ventilation, which is common clinical practice. So we labeled as an NIV only those patients who received this treatment at day 1 and 2. So in these patients, really, we believe clinicians decided to go on with NIV. So maybe this is a little bit too conservative, and the reviewers were not super happy at the first stage of the manuscript, but we have tried to explain better our rationale, and eventually they said, okay, it's fine. As we know, this companion paper of the Berlin definition recommends the use of non-invasive ventilation in mild ARDS or in, let's say, patients with a PF higher than 200. If we look at what happens in our population, it's really the incidence of NIV use overall is quite constant over the 3 categories of ARDS, so around 15%, and it doesn't really make a difference whether oxygenation belongs to the mild, moderate, or severe bands. And it's also, I would say, interesting and for us reassuring to notice that our numbers in terms of NIV incidence are quite similar to those that have been published by Alexandre Demoule in the first slide I've shown you. So to say that this makes us more comfortable in saying that our data are in fact representative of the entire population. So yes, NIV is used more or less in the same rate, in the same fraction of patients, mild, moderate, and severe, but we have to be prepared that if we're going to use NIV in moderate and severe ARDS, the failure rate will be quite high, so almost 1 in 2 patients will be intubated afterwards. And again, this figure could be a little bit conservative because of the day 1, day 2 classification I mentioned before. So it's a matter of whether you want to look at the glass half empty or half full. And indeed, here we are at half. One could say, well, of course, half of the patients with severe ARDS fail, have to be intubated, and we know that this is associated with the risk, but one could either flip the argument the other way around, saying, yes, yet 50% of these patients make it. If we go back to the question, is the classification based on PF ratio appropriate for NIV patient? I think our data suggests that yes, we can classify NIV patients more or less the same way like we do for invasively ventilated patients. So mortality goes, both ICU mortality and hospital mortality go up based on the severity of the hypoxemia. And so does the other, more or less, I mean, here the relationship is a little bit less straightforward, but our data suggests that not because patients are on NIV, they should be considered mild. Indeed, they can be mild, moderate, and severe. As I mentioned to you before, it doesn't make a huge difference whether the degree of hypoxemia does not impact the use of NIV. What really makes a difference, and again, perhaps you might say, okay, this we knew before, is the extent of the non-pulmonary SOFA score. So the more patient is on pressors, the more the patient has renal failure, the more likely the patient is to receive invasive ventilation, whereas patients receiving NIV have a much lower non-pulmonary SOFA score. What are the implications for PEEP, for patient management during non-invasive ventilation. So we just heard the importance of PEEP, we just heard the importance of keeping transpulmonary pressure low. There are, of course, this is not, as I said, an elegant physiological study, it's more a picture of real life, but what our data show is that these in blue are the PEEP levels which we apply normally during invasive mechanical ventilation, and as you can, first, already during invasive mechanical ventilation, the mean PEEP for severe ARDS is 10, which is, I would say, a little bit lower than what we would have expected by literature data. But what is striking is that if you decide to use NIV, you will be applying lower PEEP levels. And these PEEP levels cannot really go up in those more severe patients. So the average PEEP level was 7 for mild, moderate, and severe ARDS. And I think that a PEEP of 7 in patients with a PF less than 100 is quite low, if I'm allowed to say that. But there is also another finding that I think it's the, personally, it's the finding I think most remarkable of the study. This is the level of PCO2. I took the freedom here to write respiratory drive because I think, especially in assisted ventilation, in non-invasive ventilation, PCO2 has to do with respiratory drive. And as you can imagine, PCO2 going from mild to moderate to severe ARDS, when patients are invasively ventilated, goes up. Because these patients are more severe, they have a higher dead space, they are more difficult to ventilate, so we go down with tidal volume, blah, blah, blah. But look at this. Patients in non-invasive ventilation have a decreasing level of PCO2 the more severe they are. Why? Because these patients are free to breathe. These patients did not go to conferences listening to Paolo's talk about ventilator-induced lung injury, didn't read the book. They just feel they are dying. They want to breathe, and they breathe as strong as they can, and they drop their PCO2, and this is just a mirror of how strong these patients can breathe. So what are the implications in the last 2 minutes for mortality on the use of NIV? And again, I would like to stress the concept that this is an observational study, so what we can do is observe and make hypotheses. We cannot call any causal relationship. The crude mortality is the same. Here, I'm sorry, the slide is a bit crowded, but we have about 20-25% mortality in ICU for mild, about 30 for moderate, and about 40 for severe, which is not different between invasive and non-invasive ventilation. But this cohort cannot be compared straight away because, for example, of the difference in the SOFA score I have shown you. So what we did, I'll skip through this for the sake of time, is we used a propensity matched analysis, and it's a kind of magic technique that basically for each patient undergoing non-invasive ventilation looks for a match with a similar likelihood of dying. So these patients are now fully matched. We have 2 cohorts of patients that are matched by age, by gender, by non-pulmonary SOFA score. You see now it's perfectly identical for the incidence of care limitation decided by their physician. And as you see, our propensity match analysis show that overall there is no difference in mortality between patients treated with invasive and non-invasive ventilation. No difference whatsoever in patients with a PF ratio higher than 150, but there is a remarkable difference in patients with a PF ratio lower than 150, with patients treated with non-invasive ventilation dying more. And again, I think it was a work by Arnaud Thiel that showed that really this 150 is not a magic number, but is a reasonable threshold to separate patients who will make and those who will not make it through NIV. So we had some studies limitation. I am running out of time. I just would like to highlight the fact that we for sure had some confounders that we did not account for. But in conclusion, did LungSafe kill NIV in hypoxemic patient? As I said, we don't kill anybody, but I think LungSafe gave us some words of caution. So first, we are really not selecting patients who we give NIV to. This is used similarly across the different categories. In moderate to severe patients, failure rates are high. We will pay the price of the freedom we are giving to our patients because ventilatory management is very different. And we know that we have shown an association with a worst outcome in patients with a PF lower than 150. Thank you very much for your attention. Thank you.
Thank you, Giacomo. Any question from the audience? Giacomo, I don't remember one thing. Did CPAP was included in the NIV? Yes. The second question, do you have data whether NIV was used continually or intermittently?
I think those are the two questions I wish someone had asked us 4 years ago when we designed the study. If I could go back in time, I think I would fix these that are, in my opinion, two of the limitations of the study. We did not collect any data on interface, so some patients were on helmets, some patients were on face masks, and we actually do not know how long the NIV was used for. So we knew that when the data were collected, patients were on NIV, but of course with mechanical ventilation it's easy. You're normal. If you're on the day before, you're in between, you knew what happened. With NIV, we don't have this data. So I think this is a major limitation of the study, and thank you for giving me the time to bring this up.
Thank you so much. Last question?
Thank you, Giacomo. Just one question. Are you sure we never select our patient to use an NIV in ARDS? Because not on PO2 FRO2 ratio, I'm okay, but according to the amount of SOFA, non-pulmonary SOFA, more the SOFA increase, less we use an NIV. So doctors do the job correctly, no?
Well, yes, I agree with you. I'm not saying that the doctors are not doing the job correctly. I'm saying that while pulmonary component of SOFA score is not really relevant, the other components, so pressures, are taken into account, and this makes a lot of sense. I agree with you on that, but perhaps the fact that we think that the patient has just a respiratory problem misleads us a little bit sometimes and lead us to the use of NIV when maybe it would be better to switch to intubation. That's the point.
Thank you so much, Giacomo.